Hello, and welcome to another session of Digital Slide Review and Sign Out. I'm Dr. Louis Hassel, and our program is part of the Digital Anatomic Pathology Academy, a joint venture with Path Presenter. Our case today comes from the realm of bone and soft tissue pathology. It's not a challenging case per se, but I think we have some interesting materials to share that may be enriching for your diagnostic experience. So as we move on to the first slide, the patient is a 49-year-old woman who's had some knee pain, a little bit of swelling, not really so forth, but she just noted a mass that has developed following a recent trauma. I think one of her angry children got after her. This lesion then created some concern, and she sought clinical care. Well, routine radiographs don't show us a whole lot. I think you can see that she's skeletally mature. She's begun to develop a little bit of degenerative disease. We can see some calcifications maybe in the cartilage here, but we don't really see much in the way of a mass lesion or distortion. Looking a little further at additional studies, however, the MRI shows a non-fatty lesion here adjacent to the patella. And here we can see on the fluid sequences that it is just beneath the tendon here and essentially immediately abutting the joint space here, maybe indenting it slightly. With contrast studies, it lights up slightly. It is somewhat vascular, but not really bright. So it does have some vasculature to it. So what is the differential for a lesion like this? Well, radiographically, I think most people would say the first and most likely thing is a tenosynovial giant cell tumor or PVNS type of lesion. Some vascular lesions, angiomas or AV malformations can occur in the synovium, and they would, of course, be a consideration given the contrast appearance. Synovial osteochondromatosis, not particularly likely, or lipoma arborescens in this situation because neither of these the MRI characteristics don't suggest fat and don't have sufficient fluid to suggest osteochondromatosis. A sarcoma, of course, could be consideration. Bone-derived or synovial sarcoma or various other sarcomas might occur in a small lesion like this. Metastasis should be considered. Not a common feature to synovial tissues, but it does happen. And then various infectious, especially granulomatous lesions, are prone to form mass-like lesions. Gout, such deposition diseases, and various cystic lesions could also round out their differential radiographically, although, again, these would have different MRI characteristics and so can be excluded on that basis. So the lesion was resected. And here we see this nice rounded lesion, somewhat of a lobulated architecture, a few bands of collagen, and variable cellularity, some very densely cellular areas, as well as less cellular areas. We also get a sense for the staining characteristic in that you'll notice there's a little bit of gray brownish material in some of the areas of this tumor, less so in others. As we come to magnify this a little bit higher, we can see that this is indeed pigment. We have some sort of foamy clear cells here, and we can see that there is a nice granular hemosiderin type of pigment here amidst the vascular background, and a few admixed histiocytes here in this case. Looking a little bit further, we see that some of the histiocytes contain this pigment. Of course, pigmentation always raises consideration of melanoma, and if that was a serious consideration or a history, we might do various stains for melanotic markers. Here again, you can see more histiocytes in the background, vague vasculature, And then as we look over here in another more cellular area, we see these sort of clustered dark cells, quite large, that are the characteristic giant cells, osteoclast-like giant cells that can be found in this tumor. Now looking additionally, we see here that the cellular makeup is somewhat of these more histiocytoid cells with eosinophilic cytoplasm, and then there are some smaller stromal cells about as well. Still some hemosiderin in these areas. Here's some of those smaller stromal cells that we were mentioning. So this is certainly consistent with a tenosynovial giant cell tumor of the localized type. These tumors generally have a lobular configuration. They have several different cell types. There's a mononuclear histiocyte-like cells, variable numbers of giant cells. Some have a lot, some have very few or even none. There are some smaller stromal cells, the hemosiderin deposition we've mentioned, foamy histiocytes, and a variable sclerotic and vascular background can also be seen. Now, if you need to do immunohistochemical stains, and I can't recall a case where I have actually had to do so, it may show positive staining with clusterin in the larger cells, majority, but not all. The small stromal cells will stain with macrophage markers, as would, of course, the foamy cells. And the giant cells would stain with CD68, tartrate-resistant acid phosphatase, although I can't imagine doing that. So I thought it would be useful to just look at a few additional examples, not from the current patient, but just to further give you a range of the a feeling for the spectrum of this disease. So here again, we see a lobular lesion. You see this, recognize this brownish pigmentation and paler areas with some vasculature. We come into higher magnification. Again, we can see these small mononuclear cells here and some admixed foamy histiocytes in here. The vascular background, as we've indicated. Fair number of giant cells and some hemosiderin again, as we've noted. So just to get a feel for the spectrum, here are relatively few giant cells in this case, a mixture of histiocytes and other cells. Another example, different laboratory, different staining characteristic, very pale looking because of the nature of their H&E stain. And we don't see the pigmentation here. So that's a variable feature, but as we come in here, I think you'll begin to recognize the pattern, a bit of sclerosis in the background, and a mixture of these histiocyte-like cells, eosinophilic cytoplasm, fairly bland looking, rare giant cell in this case, a little bit of hemosiderin, not a lot, didn't stand out at low magnification for sure. And relatively few of the foamy histiocyte type cells. Now, on occasions, this collagenous matrix can begin to look almost osteoid-like or even chondroid-like. So there is some borderline features with some of those osteochondromatous lesions of the synovium as well. Here, one additional case, again, very different histology, much more darkly stained from a different laboratory. But again, at low magnification, we can begin to pick up these giant cells. We see the sclerotic background, bit of vasculature, and a very bland looking mix of these histiocyte-like cells, modest amount of cytoplasm. No particular atypia, not much in the way of mitotic activity. If you were to find it, you'd be lucky. So those are all very useful features. And then one last case here, again, to illustrate the spectrum, a little bit less obvious lobularity, but sort of lobular overall. And I think even at this very scanning magnification, you can appreciate that there are some giant cells in here. And they begin to pop out as quite abundant as we come into higher magnification. Now in this lesion, notice how the sclerosis is, as I indicated, almost osteoid-like. And so with giant cells in a sclerotic pattern like this, you might begin to be concerned for a osteogenic lesion and worry about a so-called osteochondroid synovial change sort of thing. But I think as you look a little further, you recognize that this is more characteristic of a giant cell tenosynovitis or giant cell tumor of tendon sheath. So what's the pathophysiology for this lesion? Well, interestingly, up to 50% of patients do report some feature of trauma, although it's unlikely that this is specifically a traumatically induced lesion. There may be pain, swiftness, and of course, stiffness and swelling, along with recurrent hemarthrosis, especially in the non-localized variant. That's a characteristic feature. And this is a non-traumatic hemarthrosis. It's been discovered that this is due to the pathophysiology of this is related to overexpression of CSF1 gene product. And this can be due either to mutation on 1p13, which is the more common finding, or a rearrangement of 5q33. Males and females equally affected, usually middle age, and the most common locations are the knee, large joints, hip, elbow, shoulder, before you encounter it in other locations. But you should not be deceived, because this can occur in more distal locations. Here's a clinically swollen digit, which on further evaluation, excision, was found to be a subcutaneous tumor with this nice giant cell proliferation. Not very big, but you can see it's sort of in the tenosynovial type tissues, and has some hemosiderin deposition here. It has the features that we've identified. A bit more vascular at this stage, but still fits into that category of localized giant cell tumor of the tendon sheath. In terms of treatment for these patients, obviously, this is a benign disease, so observation can be employed if it's not clinically significant, or there's not difficulty with pain or other issues. Resection arthroscopically or a marginal type of excision can be performed. For those patients who where it cannot be easily excised, or where it's not having difficulty controlling it, or it's recurring, CSF1 inhibitor can be used. This is a fairly newly approved drug, and I don't have a whole lot of knowledge about how it's managed at this point, but it is out there. Another possibility that can be employed, particularly in cases that are recurrent or where you have the disseminated form, is that radiation can control spread and reduce the proliferative nature of the lesion. So that's our case for today: a tenosynovial giant cell tumor of localized type occurring in the knee of a middle-aged woman, resected completely, and she should do very well in follow-up. Well, we hope you enjoyed that case, and if you like that, please give us a thumbs up. That helps more people find our videos, and also, of course, we hope that you'll subscribe so that future releases from our channel will be provided to you as a quick alert as well. As always, I'm open to your feedback directly, either at my email, Twitter, or of course, in the comment section below. I'll post the link to the digital slides so that you can come back and study these cases on your own to further cement this lesion in your diagnostic retinue. But until next time, thanks so much for joining me.